To the 16th Annual Hybrid Sickle Cell Disease Educational Summit, Unpacking Sickle Cell, one warrior at a time. We are excited to begin our afternoon session, Gene Therapy, with two outstanding moderators who bring a wealth of knowledge and experience to the sickle cell community. First, let me introduce Adrienne Shapiro. Adrienne, co-founder of Access Advocacy SCD, became a passionate patient advocate after her daughter Marissa's sickle cell diagnosis was missed due to a false negative test. Awarded the Stem Cell and Regenerative Medicine Action Award in 2018. Adrienne has been a tireless supporter of stem cell research and a fierce advocate for improved care and housing for those living with sickle cell disease. Joining Adrienne is Dr. Donald Ivy, Vice Chief Medical Officer for the Sickle Cell Disease Association of America, SCDAA. Dr. Ivy has worked with the Health Resources and Services Administration, HRSA, and the National Heart, Lung, and Blood Institute. He completed his medical training at East Carolina University School of Medicine and earned a master's in public health with honors from the University of North Carolina at Chapel Hill School of Public Health. Together, Adrienne and Dr. Ivy will guide us through this vital session on gene therapy and its potential to transform the future of sickle cell care.
Hello, good afternoon, everyone. Can you hear me? Yes, okay. Good afternoon, everyone. Thank you so much. I would like to thank Dr. Carolyn Rowley and the Cayenne Wellness Center for inviting me here to speak during this session on the very important topic around gene therapy. My name is Edward Donnell Ivy. I do go by Donnell, and I'm the Vice Chief Medical Officer for the Sickle Cell Disease Association of America. In addition to being the Vice Chief Medical Officer for SCDAA, I am also a person living with sickle cell disease. I have known the struggles of living with sickle cell disease since very, very young. I can remember back at 2 years old when I started having painful crises in my joints and arms and legs. I grew up with the burden of sickle cell disease and experienced very frequent painful crises, avascular necrosis in my hips, and other difficulties with sickle cell disease. When I was a young child, I wanted to be an Air Force pilot. But unfortunately, in high school, I learned that I wouldn't be able to fulfill my dream of being an Air Force pilot. As my favorite author and writer says, it was a dream deferred. And even though that dream was deferred, I could have gotten angry and exploded because of it. I could have sagged and become depressed. I could have done a whole number of other things. But what I did was declare war on sickle cell disease. I said, since sickle cell disease had taken away my dreams, I was going to fight as hard as I can for the rest of my life to defeat sickle cell disease. And with that in mind, I was fortunate enough to be the first person in my family to go to university. I enrolled at North Carolina State University to pursue a career in healthcare to really fight against sickle cell disease. But even in college, the burden was very difficult. I would often have crises that would cause me to be out from school weeks to months at a time. And it was very difficult trying to complete college while you're out from your lessons because of sickle cell crises. But I really endured. I was fortunate enough to work with the doctors at the North Carolina State University Infirmary. They were willing to work with me on treating my sickle cell disease. But there were times when I had to be hospitalized and I had to go to the local hospital in order for more extensive treatment. In my third year of college, I had an episode of acute chest syndrome, and I went to the local hospital in Raleigh, North Carolina. And I'm very thankful that they had the foresight to see that my situation was not improving with the care that they were giving me, and I was getting sicker. So what they did was they reached out to the hematologists, sickle cell experts that were at the University of North Carolina at Chapel Hill, and I was transferred from the hospital in Raleigh to the hospital in Chapel Hill. It was meeting Dr. Gene Oringer, a specialist in sickle cell disease at the time. that started really managing my care around the acute chest syndrome. And as I got better, he talked to me about getting on hydroxyurea. Now, at that time, of course, hydroxyurea was a study medication. There was still research being done on it. And I was a little skeptical about starting hydroxyurea. But fortunately, I had a hematologist that was part of the study that really encouraged me to begin taking the medication. I do remember that it was one thing that he said. He said, Daniel, you know, the situation might be that I'd start taking hydroxyurea, and sure, 15 to 20 years from now, I develop cancer from taking hydroxyurea and die from the cancer. But he said to me, but Daniel, you have a very serious disease. And I had just had an episode of acute chest syndrome. He said having that episode of acute chest syndrome increased the likelihood of me having another acute chest syndrome. And he said, Daniel, you can get an acute chest syndrome within 6 months and die from that. So we have to recognize that sickle cell disease is a very serious disease. We must take it seriously, and we must look at all of our treatment options. For the longest time, I started hydroxyurea, and for me, it was a game changer. I went from having 4 crises a year to not having any. I was able to finish undergrad, my last 3 semesters on the dean's list, and then I was able to go on to medical school at East Carolina University School of Medicine. And it was during my residency, I was able to complete medical school, and during my residency, what I observed is that a lot of patients with sickle cell disease were not taking hydroxyurea. There was a lot of barriers to individuals with sickle cell disease taking hydroxyurea. Some of those barriers were with the patients, and that they weren't educated about hydroxyurea. They didn't know about it. There was the burden of having to get frequent tests done when you're on hydroxyurea. And then, of course, there were a lack of providers willing to prescribe hydroxyurea. So it was during that time in my residency that I said, we have to do something to improve access to care. What's the use of having wonderful therapies that can really treat sickle cell disease if the patients that need them aren't able to get access to those therapies? For the longest time, hydroxyurea was the only therapy out there for sickle cell disease, of course, besides pain meds and blood transfusions. And there was bone marrow transplant, but it was very limited to individuals that had a matching sibling donor. But fortunately, as most of you are aware, last year, the FDA approved 2 new therapies, gene therapies for the treatment of sickle cell disease. We're at a very critical time for sickle cell disease where we are actually looking at the possibility of a cure. But as we move forward into this new future, this new reality, we have to think about how we help individuals get access to care, get access to this gene therapy, and get access to other therapies such as hydroxyurea and other therapies that are out there now. We do have more therapies like Voxelotor, we have Adakveo, we have Endari, and we want to make sure that as we proceed, individuals with sickle cell disease have access to care. That's why, as the Vice Chief Medical Officer, I'm happy that I get to work with community-based organizations such as the Cayenne Wellness Center to figure out strategies to really educate the community about these new therapies and work on pathways to improve that access to care. The only slide I have here to show you is that the new gene therapies, though, is going to be a path. And that path is going to take some time. And we have to realize that if we want our patients to have access to this therapy, we need those systems and that infrastructure in place that can help educate the patients about the new therapies and guide them along the path to receiving the new therapies. So the work is just starting. We're at the very beginning right now. And I look forward to working with Cayenne Wellness Center to continue to advocate for individuals with sickle cell disease, to work on that pathways to ensure that patients have access to not only the gene therapies, but also the other therapies that exist for individuals with sickle cell disease, such as hydroxyurea, such as Voxelotor, such as Adakveo, such as Endari. We have to make sure that we're providing that education not only to our patients, but also to the providers that treat those patients to make sure that the sickle cell community, those individuals who are suffering with sickle cell disease, can have the most prosperous and longevity life possible. So it is with that I will say thank you. I look forward to being the moderator during our discussions. We will have discussions on the history of gene therapies and then talking about that in-depth part, because one, we know that everyone won't choose to do gene therapy. But for those that do, we want to look at how we make the system easier for them to benefit from that. So with that, I'll turn it back over to Adrian Shapiro, and I look forward to talking to you this afternoon. Thank you.
Thank you, Dr. Ivy. So I love how he summed that up. So you didn't have to hear about my journey with my brother, my mother, my family, but all of us that are here today, I just want us to take one big breath before we get this information. And I just want us to have that moment.
Adrian, can you do us a favor and talk into the mic?
Oh, I'm not, oh, sorry about that.
It's okay.
I want us to have that moment. I'm just excited to get that energy going. And let's just breathe out, breathe in from hydroxyurea to what in how many years? Just for a minute. When we started this journey, they told us it was going to be the 2030. We're like, nope, not going to happen. Not here. Just have it for a moment. Okay. Okay. All right. Okay. So we're going to start like getting into the nitty gritty of this. And shall we, there's going to be another video, right? I'm just trying to get the rhythm. Yes. And we're going to have our next speaker up. I don't want to be redundant because you have your own video, your movie star.
First session of the afternoon titled History of Gene Therapy, How We Arrived, Why Sickle Cell is the Poster Child for Gene Therapy, and How It Benefits Others, featuring a remarkable speaker who brings a wealth of knowledge, experience, and expertise to the sickle cell community. I'm pleased to introduce Dr. Akshay Sharma. Dr. Sharma is a clinician scientist at St. Jude Children's Research Hospital specializing in bone marrow transplantation and cellular therapy. His research focuses on the genetic regulation of fetal hemoglobin and the development of gene therapy trials for blood disorders. Dr. Sharma leads innovative clinical trials and is a strong advocate for equitable access to curative therapies for sickle cell disease. In this session, Dr. Sharma will provide valuable insights into the evolution of gene therapy, why sickle cell disease is at the forefront of this groundbreaking science, and how it benefits not only sickle cell patients, but others as well. Welcome again, and thank you for being part of this important event.
Wow, thank you so much. That picture honestly was taken a couple of years ago, and I should say it looks better than I look right now. So you guys are lucky. All right. I'm sharing my screen. Can somebody confirm that you guys can see my screen?
Yes, we can see it.
Okay, perfect. All right. So it says, I'm going to be talking about history of gene therapy, but let me tell you that we are living the history right now. So rather than talking about the history, I'll talk about the current state of gene therapy for sickle cell disease. These are my conflicts of interest and disclosures. I work with a lot of different companies that are developing gene therapy clinical trials, and I work with them to improve how we develop these therapies. But none of the work that I'm presenting today is related to any of these disclosures. So I'll briefly start with the genetic basis of sickle cell disease and then compare how bone marrow transplant that Dr. Ivy was talking about compares to gene therapy. We'll then dive into the different types of gene therapy and talk about some of the results of clinical trials. And then towards the end, we'll talk about how do you pick which treatment you should choose. And so I show this slide to most people that I'm talking about. You know, in order to understand a genetic disease, you have to understand where genes are. So as you probably know, we all have trillions and trillions of cells in our body, and inside those cells, we have chromosomes. And on these chromosomes, we have genes which are made up of DNA. So in order to compare this thing to something we are more familiar with, if you think of cells looking like books, the chromosomes are essentially like book chapters, and the sentences in those chapters are the genes. And just like you can have a spelling mistake in a sentence, you can have spelling mistakes in these genes, and sickle cell disease is nothing but a spelling mistake in the gene that codes for hemoglobin molecules. And so on chromosome number 11, Inside blood cells, we have a gene which codes for the hemoglobin molecule HBB, and instead of GAG, there is a GTG, and that's the spelling mistake. As Dr. Ivy also mentioned, there are many, many treatments available for sickle cell disease right now. We have known about blood transfusion since the 1980s. Hydroxyurea has been around for many, many years. And within the last 10 years, L-glutamine, crizanlizumab, and voxelotor were also FDA approved. But the issue with all these medicines are that they need to be taken on a regular basis, either every day, every week, every month, or even if you take them regularly, they may not work for you, and they don't work the same for every individual across their lifespan. So they may work for you initially, but then they may not work for you later on. So it's a very different sort of approach with each one of these medicines, which is why we don't think that they are a curative therapy. We've also known about bone marrow transplant, or BMT, since 1983, when it was first performed. And then last year in December, not one but two gene therapies were FDA approved for sickle cell disease. And so how do we do bone marrow transplant? Let's talk about that first, and then we'll dive into gene therapy. So let's say this is an individual with sickle cell disease here, and on the right side, this is what their blood looks like. As you can see, there are a number of sickle cells over here. So the first thing that we have to do a transplant is to find a donor. Now, the best donor is usually a brother or a sister who's a full match to you, but does not have sickle cell disease. Now, the chances of finding a brother or sister who's a full match but does not have sickle cell disease is usually 1 in 5 to 1 in 10. So imagine if you have 5 to 10 siblings, maybe one of them will be a full match and doesn't have sickle cell disease. So that's a fairly rare chance, if you ask me. Now, for those lucky individuals that have a fully matched donor, we collect stem cells, bone marrow stem cells from that donor. Then we give the patient with sickle cell disease chemotherapy and or radiation. And the purpose of this chemotherapy and or radiation is to kill the blood cells that make sickle cells. So after chemotherapy, their bone marrow becomes empty. And then we take these cells that we have harvested from the donor, and we put them back into the patient and wait for a couple of weeks. And as these blood cells start growing and start making new blood cells which look just like the donor, our patient does not have sickle cell disease anymore either. Now, that all sounds very simple, but of course, there are problems with this. First thing, as I mentioned, not everybody has a donor available, but even if you have a donor available, there are some immune problems associated with bone marrow transplantation, the two main being graft versus host disease and graft rejection. Whenever we put cells from one person into another person, there is a chance that the recipient may reject those cells, which causes graft rejection, or the cells go into the patient and start attacking the patient, something called graft versus host disease. And both of these problems can be life-threatening if they're not controlled properly. When we use chemotherapy, people lose their hair. This is temporary, but it's a big deal for many individuals. Also, chemotherapy exposure can affect the way your kidney, your ovaries and testicles work. And so some individuals may not be able to have children after receiving chemotherapy. And then chemotherapy also reduces your ability to fight infections, at least transiently. So there is a risk of catching infections, and there is a low but non-zero risk of developing cancer and maybe even dying because of the exposure to chemotherapy. Now, while we can't fix all of these problems, the first three problems over here, not having donors or the risk of graft versus host disease and graft rejection, we can address that if we use a person's own cells. And so that's where gene therapy comes in. So in gene therapy, once again, this is a person with sickle cell disease, and on the right side, this is what their blood looks like. You can see there are a lot of sickle cells. In gene therapy, instead of finding a donor, we actually collect stem cells from the patient himself or herself. We then take these cells to the laboratory, where we use either a lentiviral vector or CRISPR-Cas9 protein to genetically modify these cells. once these cells have been modified, we still have to use chemotherapy to wipe out the sickle producing cells. And once these cells have been completely wiped out from the bone marrow, we infuse these genetically modified cells into the patient and wait for a couple of weeks for them to grow. And as they grow, they start making normal blood cells, and the person doesn't have sickle cell disease anymore. Now, there are many different kinds of gene therapies. We can do gene addition, gene replacement. We can increase fetal hemoglobin by a number of different methods. And last but not the least, we can fix the sickle cell mutation. Now, that last part over there, fixing the sickle cell mutation, it's much harder to do than it is to say. And so as of today, there are very few efforts or clinical trials which are actually fixing the sickle mutation. There's actually one clinical trial going on in California, but the first two approaches of gene addition and increasing fetal hemoglobin, these are the ones which are FDA approved. So let's talk about gene replacement or gene addition first. Now, as I told you, sickle cell disease is caused due to a spelling mistake, right? And so here I have a sentence which has two spelling mistakes, as you can see. What this technique does is it basically adds the normal spelling of the gene somewhere in the sentence. So in your genes, they will add a normal copy of the gene, which the normal spelling is, somewhere. And we use a modified HIV virus to do that. That's a lentiviral vector. Now, this is a HIV virus from which the HIV causing machinery has been removed. So this virus cannot cause HIV/AIDS, but these viruses are very good at transferring genes inside blood cells. So we use them not just for sickle cell disease gene therapy, but for many, many gene therapies. And it's very safe and it does not cause HIV. So we use that to put the normal spelling of the genes somewhere in the sentence. And this is the method. So what we do is we take an empty HIV virus, a lentiviral vector, we package a normal gene inside, and then this virus goes inside the blood forming cells, delivers the normal gene, and now you make normal hemoglobin again. So this method is what was used to develop this product called Lovotibegdogene autotemcel or Lovocel. The trade name for this is Lyfgenia. And this is an FDA-approved medicine for individuals who are 12 years and above. This was developed by a company called Bluebird Bio, and on their clinical trials, they treated at least 47 patients who were followed for about 1 month to 60 months. And as you can see on the right-hand side, these are the average hemoglobins of the individuals who were treated. And before infusion at baseline, the average hemoglobin was about 8, but after treatment with this, the hemoglobin rose to about 10 to 12, around 12 grams, which is near normal. And as you can see in the blue over here, half of that hemoglobin was coming from the virus that was introduced. So by doing this individuals, instead of having sickle cell disease, they become like somebody who has sickle cell trait. The next approach is to increase fetal hemoglobin. Now, we've known for a very long time that if you have more sickle hemoglobin, you have more pain, more acute chest, poor quality of life, and a shortened lifespan. Hydroxyurea increases fetal hemoglobin, and that reduces pain, that reduces acute chest, improves quality of life, and improves lifespan. Now, if we could do that, if we could raise fetal hemoglobin without having to take hydroxyurea every day, that would be fantastic. And that's what gene therapy does. So once again, here is the spelling mistake. Now, we can use CRISPR-Cas9, which are like these small molecular scissors, which go and cut the genes at any place that we want them to. So by cutting the genes, we can introduce random words within those sentences. And so this is essentially what it looks like. In scientific language, these are called insertions and deletions or indels. So sometimes when I'm describing this technique, instead of calling it gene editing, I like to call it gene vandalism. But I can tell you that the gene editors don't like that very much. So let's just stick to gene editing right now, but it's gene vandalism essentially. But what happens is this sort of gene vandalism is good for us because by doing this, we can raise fetal hemoglobin. So this was developed in a product called Hexagamglogene Autotemcel. The trade name is Casgevy. This is also FDA approved for individuals over 12 years. And it was developed by two companies, CRISPR Therapeutics and Vertex Pharmaceuticals. On their trial, they treated 44 patients and followed them for about 1 month to 5 years. And again, as you can see on the graph at the bottom, the average hemoglobin went up from about 8 grams per deciliter to about 12 grams per deciliter in these individuals, and at least half of that was coming from fetal hemoglobin. And so once again, these individuals, because they have so much fetal hemoglobin, they don't have sickle cell related crisis after that. And most of the individuals on these two trials have not had any sickle cell related pain crisis after undergoing gene therapy. There is another product which is currently in development by a company called Editas. This is called Ranicell. This is not FDA approved right now. This also uses a similar CRISPR approach to raise fetal hemoglobin. They have treated 11 patients so far. And once again, the results are very similar to the previous trials that we have seen. So as I mentioned earlier, CRISPR-Cas9 does this. It changes, it adds random words or alphabets within the sentences. It would be ideal if we could go and correct the spellings. And base editors, which are even a more newer technology, can do that. But this is yet to come in clinical trials. Now, I told you earlier that there are some problems with bone marrow transplant and how gene therapy can fix at least the first 3 problems, because every patient can potentially serve as their own donor. You don't have to find a donor. But the problems listed here on the bottom still remain. Most clinical trials and most products, gene therapy, still require you to take high dose chemotherapy. And these chemotherapy can cause hair loss, infertility, infection, cancer, death. All those things can still happen. But more than that, we run the risk of having some unknown risks. And so a couple of years ago in 2021, Bluebird Bio announced that 2 patients on their clinical trial developed leukemia. Now, viruses can also cause leukemia. And so if you have, this is what our lentiviral virus is supposed to do. It is supposed to insert the normal spelling at the end of a sentence. But if it inserts the normal spelling at the wrong place in between a sentence, it could even further change the meaning of that. And this is what happens if when we have a virus that causes leukemia. We call it insertional leukemogenesis. Now, this is not what happened on the Bluebird trial, though this is a theoretical risk. It could happen. Extensive evaluation was done, and these 2 papers were published subsequently, and they clearly showed that the virus was not involved in the development of leukemia in these patients. But nevertheless, these patients got high-dose chemotherapy, and we know that chemotherapy exposure can also cause leukemia. So we wonder whether that might be what happened. Now, since then, since those 2 patients, no other patient has developed leukemia, but that risk is still there. And we need to talk about that. And we need long-term follow-up from these studies. These studies have only followed patients for about 5-6 years. We need to follow these patients really, really long, 15 years, 20 years, to really understand what the risk is from these novel therapies. I also want to bring up this question of what a cure means. It probably means different things to different people. You know, some would say if they don't have any sickle cell associated pain crisis, or they don't need medications or blood transfusions, that's a cure. But what I like to tell patients is, if your body is like a wall, sickle cell disease is like a hammer, which keeps chipping on that wall every single day. Transplant and gene therapy takes the hammer away, but it doesn't really repair the wall. So the damage that's happened to your body because of sickle cell disease before you undergo gene therapy or transplant, like if you have had a stroke or osteonecrosis or heart damage, kidney damage, lung damage, that will remain and will continue, and you will still have to see a physician after undergoing gene therapy or transplant to take care of those. Gene therapy and transplant only affect blood cells. So if an individual with sickle cell disease were to have children, they can still pass on the sickle gene to future generations. And so we need to make individual assessments for every patient, whether gene therapy or transplant is right for them. Remember, even on the gene therapy clinical trials, there are some patients who continue to have pain afterwards. There are very few, a handful of them, but they are not zero. There are some patients who can continue to have pain after undergoing gene therapy. So once again, cure is a very heavy word, and what it means for different people will need to be individualized for them. So what I would leave you by saying is that gene therapy is surely transformative, hopefully in a good way, but it could cause some bad things too. And so this is the question I am usually asked. Which one of these therapies should I pick? Which one is the best? Just tell me and I'll do that. The short answer is we don't know. I don't know. I can't tell you if one of these technologies is better than the other. Surely there are very impressive short-term results, 5 years, 6 years, but we don't know what the long-term safety and efficacy of these therapies is going to look like, whether one is going to be better than the other. So what I usually tell patients is, if there is a trial available and you have severe disease, consider participating in that trial. It will probably help you, but at least it'll help advance these therapies for all other patients around you. And St. Jude does have a gene therapy trial, which is open and enrolling. So if you are interested, please contact me and surely discuss with your family and doctors to see if this is the right option for you. There are known risks and there are unknown risks, and it's a decision that is highly personal, and you should all make that decision for yourself in discussion with your physician and your family members. And so this is that shameless plug that I was telling you in the last slide, that we have a clinical trial at St. Jude, which is currently enrolling individuals between 18 to 25 years. If you have SS, S beta 0 or S beta plus disease and have severe disease, which is defined as having at least 2 sickle cell related events per year for the last 2 years, please reach out to me. My email address is here at the bottom, akshay.sharma@stjude.org. And I'll be happy to discuss this further with you. So with that, I thank you very much for your attention. And this is one of my patients who gave me the permission to share his picture over here. He and I partnered together, and he decided to participate in a clinical trial a couple of years ago. And he's about 3 years out and does not have sickle cell disease anymore. And I hope that all of you listening in the audience can have a similar fate as he did. So thank you very much once again for your attention, and I'll be happy to take any questions now.
Thank you, Dr. Sharma. We're going to take questions at the end of the session. Will you be around then?
Yes, I'll be around.
Great job. Okay, next up, we're going to have Dr. Alexis Thompson. She's going to talk to us. Am I just off? I am. Okay. We're going to have Dr. Alexis Thompson, who we know and love, and she's going to talk to us about the 2 new treatments and then help us, because we're all asking
We are
the
excited to
question,
begin
am
our
I a
next session.
good candidate for that? Okay, thank you.
We are excited to begin our next session titled 2 FDA-approved gene therapies and what makes me a candidate, featuring a remarkable speaker who brings a wealth of knowledge, experience, and expertise to the sickle cell community. I'm delighted to introduce Dr. Alexis Thompson, the new Chief of Hematology at Children's Hospital of Philadelphia, CHOP, where she leads a top-tier program for pediatric hematologic disorders. A graduate of Tulane and UCLA, Dr. Thompson has extensive expertise in advancing care and research in sickle cell disease, hemoglobinopathies, and stem cell transplantation. In this session, Dr. Thompson will provide valuable insights into the evolution of gene therapy, why sickle cell disease is at the forefront of this groundbreaking science, and what makes someone a candidate for these innovative therapies. Welcome again, and thank you for being part of this important event.
Good afternoon. Can anyone see? There we go. Let's see if we can see my desktop here. Mm. Sorry, just gonna see if I can get, here we go. All right, good afternoon, and thanks so much. I've really enjoyed Dr. Akshay Sharma's talk. Can you see my slides now?
No, we do not see your slides.
Okay, I can, I'll try it again. Are you able to see my desktop?
No, we are not. Oh, wait, it's coming up right now. There we go. We see it.
Okay, fantastic. Great. So I'm just going to try to see if I can get it. Now, do you see the full screen now?
Yes, we do.
Great. Okay. Well, good afternoon. Thanks so much for the opportunity to talk to your audience about the two the approved therapies and what makes me a candidate. So these are my disclosures. They include a number of the leaders in the industry on gene therapy as a consultant in research. So what I'm going to hopefully cover, and I suspect that maybe some of your, I'm just going to be reinforcing at least some high-level things that perhaps other speakers have already covered, but progress and the remaining challenges in sickle cell, how we think about the different potential approaches to gene therapy, what the strategies are. You just heard some of the recent results. I'll reiterate those, but then we'll focus a little bit deeper on considerations for patients who are interested in gene therapy. This, I hopefully don't have to convince this audience that we have made progress with sickle cell disease, largely in the last 50 years, beginning with the National Sickle Cell Act, which funded research from federal funding, the introduction of penicillin prophylaxis and newborn screening, which certainly saved lives and prevented deaths in early childhood, carboxycarbamide or hydroxyurea, now recommended for all ages, and then finally, transcranial Dopplers and a painless ultrasound of the brain or the vessels in the brain, and the combination of that with transfusions also preventing strokes. And so while certainly this is progress, I think it's important to point out that there is still a gap between all Americans and individuals with sickle cell disease that's between 2 and 3 decades. So clearly more work to be done. The area that I think for many of us is of greatest concern is in the middle of this slide, which is actually the crude death rate based on age, different age cohorts. And the ones in the box are the patients between the ages of 20 and 50. And as you can see, that certainly is not a normal curve for mortality for any other populations. And so this excess mortality that's occurring in adolescents and young adults needs to be the highest priority in terms of how we should be moving forward. I suspect that some of your other speakers have covered current drug treatments, hydroxyurea, and some of the other disease-modifying therapies. I'll touch briefly on allogeneic stem cell transplants, but we'll be spending most of my discussion about ex vivo gene therapy. Hopefully in the next few years, we'll be talking about in vivo gene therapy, but not today. But certainly that is a future treatment that I think has some really promising early laboratory results. HLA-matched sibling donor transplants today should be considered standard of care as a curative option for sickle cell disease. This slide summarizes information on over 1,000 individuals globally, so in a variety of different countries, all combined into one paper that really gave us incredibly good news that was very consistent. And that is that when you have an HLA-matched sibling donor as the source of the stem cells, there's a fairly low rate of chronic graft versus host disease, which is a really enormously troubling complication of transplant. And there's very high overall survival, especially if the source of the bone of the stem cells is either bone marrow or cord blood. These results are better in younger individuals, and so the results were certainly much better in people below the age of 14 years. It was also better more recently. So patients who were transplanted between 2007 and when this paper was published in 2017 had done better than the ones in the years prior to that, largely because supportive care had improved. There are a number of factors affecting transplant outcomes. First and foremost, the severity of sickle cell complications prior to the transplant itself is a very important factor. So to the extent that someone has serious organ injury and permanent injury to certain organs, it's not clear that transplant will necessarily reverse them. In fact, for some, we hope that it will slow down, or at least that there won't be any further harm. But the realities are that if there are injuries to organs prior to transplant, that this may reduce the outcomes. The source of the donor stem cells I've already mentioned, whether it's bone marrow, peripheral blood, or umbilical cord blood, are all sources that can be used. The availability of a sibling donor is important, but certainly there is emerging research using alternate donors, family members that are partially mismatched, and then matched unrelated donors. The preparative regimen, or the conditioning, which is most often chemotherapy, but in some studies can be radiation therapy, is a critical part of the success of transplants, but also is a source of some of the major complications. I've already alluded to age being important, at least for allogeneic stem cell transplants. Iron status also matters, and this relates to the need either for chronic transfusions for sickle cell patients, or even patients that are only transfused periodically. Iron accumulates each time you get blood, and if you've gotten blood even intermittently over many years, you will have excess iron that can impact the function of certain organs that will make transplant more complicated. But there are a number of considerations, not the least of which is most patients with sickle cell will lack a suitable match-related donor, and in fact, they may have great difficulty even identifying an unrelated stem cell donor through things like Be the Match or the National Marrow Donor Program. There are a number of really important open research studies that are looking at unrelated donors, some with reduced intensity, and now also partially matched or haploidentical donors that have some very early, very exciting results. There are also a number of potential complications, which you may have already heard about, including non-engraftment or graft failure, where the stem cells that are infused do not work. And so with graft failure, one can have some serious issues related to that one. Infections that are either life-threatening can certainly be a complication of those transplants. Chronic as well as acute graft versus host disease can be life-threatening. Infertility is a complication primarily of chemotherapy, and so certainly must be something that is discussed seriously. And then the risk of transplant-related mortality or death are other considerations. This has really caused people to really give serious thought to some other way to think about a transformational approach to treatment that perhaps is less risky. And that's where gene therapy comes in. What is gene therapy? In its most simple form, gene therapy overall are experimental techniques that use genes or genetic material to treat or prevent diseases. The other critical factor in what we're discussing in sickle cell disease is that the patient serves as their own donor. So it does not require having a brother or sister who matches or finding a suitable match within a registry. Today, we currently have what's called ex vivo gene therapy, which means that the patient's blood-forming cells are collected, they are removed from the body, and then they are modified ex vivo or in the laboratory and then reinfused. And as already been alluded to, there are a number of types of gene therapy: gene addition, gene editing, and now base editing. What do we expect to accomplish with gene therapy? I think many people assume that our goal is gene correction, but I will tell you that today there are no gene therapy programs that are actually able to accomplish that. We're not able to, for instance, cut out the exact gene that is affected and then insert in its place a completely normal gene at the native site. That does not happen. What we can do is gene addition, which introduces copies of a normal or normalized gene, but leaves the native gene intact. And that's important when we think about what our expectations should be for what gene therapy can accomplish. We can also modify the expression of other genes that play a role in disease pathogenesis. And this is something that is also being used now commercially and in research studies in sickle cell disease. And then finally, genome editing, where we directly repair specific sequences. Now, in the case of sickle cell disease, gene addition adds a normal beta globin gene. And so as long as the expression of that gene is pancellular, such that nearly all the red cells that are produced from the gene therapy point forward are expressing the normalized beta globin, then that person with sickle cell disease functionally could be converted to sickle cell trait. Because remember, with sickle cell trait, all of the individual's red cells are a combination of A and S. And so in theory, as long as you have pancellular expression of the normal beta globin gene, someone after gene therapy could also be AS. One can also think about increasing fetal hemoglobin because fetal hemoglobin is non-sickling. That can be accomplished by adding GABA globin, which is a building block of fetal globin. You can modify the beta globin gene to make it gamma-like, and that's also been done. Or you can alter the expression of genes that regulate fetal globin, and that is also being done. What I won't be talking about, but certainly is on the horizon, is direct correction of the hemoglobin S mutation. There are a few clinical research programs that have that as a goal, but there is not meaningful clinical data to report out on that, so I won't be covering that. This is what happens if you undergo lentiglobin gene addition therapy. And again, I think Dr. Sharma has already alluded to this. Your hematopoietic stem cells are mobilized using a drug called plerixafor, and your cells are collected by automated exchange or apheresis on a machine. This usually takes 3 to 4 days in the hospital, but the patient is wide awake. Those cells, once collected, are then sent to a laboratory facility or manufacturing site where the most primitive CD34 stem cells are purified and then transduced, which introduces the lentiviral vector that contains the beta globin sequences. After this is done in the laboratory, those cells are cryopreserved or frozen. They undergo extensive safety testing, and then they are eventually returned to a clinical site in the frozen state. At that point, the patient with sickle cell is admitted to the hospital. They're given 4 days of busulfan, which is a chemotherapy drug that's given at fairly high doses that causes what's myeloablation. Myeloablation destroys as much of the bone marrow as possible, and that is important for 2 reasons. One is it makes space in the bone marrow for these new modified stem cells to actually go back to the marrow and then take up residence. The other is that we want to reduce the number of sickle producing stem cells that the patient still has. So the patients get 4 days of busulfan, 2 to 3 days of rest, and then their drug product, which is their own stem cells that now contain a modified globin gene, are infused. Then they remain hospitalized largely to recover from the side effects of the busulfan conditioning. But during that hospitalization, we begin to see production of the gene therapy derived hemoglobin A. And in the case of lentiglobin, it is hemoglobin A that has a non-functional mutation, or I couldn't say it's non-functional. It is still a relatively healthy mutation called T87Q. T87Q happens to be a sequence that we see in gamma globin. And so this is an example not only of providing beta globin, but it's a beta globin that's a little bit more gamma-like, but certainly non-sickling in that regard. And then you also see recovery of platelets and white blood cells. The studies went for 2 years, and then everyone who's participated in these clinical trials is now in long-term follow-up. And these are some of the results from the lovo-cel lentiglobin gene addition trial. Some of you may have seen these already during this conference, but just to orient you, each one of the lines in this figure is an individual patient. And when you look out on the left, you'll see a grayer area with many red or pink symbols. Each one of those red or pink symbols is a pain episode that required hospitalization in the 24 months prior to gene therapy. Then at time 0, the patient was given their own modified stem cells back that is the lentiglobin or lovo-cel. They're allowed to recover, and then they're followed and monitored for 6 months and then followed out indefinitely. And so this is with data out to 5 years. And in the lovo-cel studies, 32 of the 34 evaluable patients had complete resolution of vaso-occlusive pain episodes. We also know that they have, once they have expression of T87Q, which in this case is in blue, that it seems to be sustained over time out again as far as 5 years. The other hemoglobin, the orange, is actually primarily hemoglobin S. But remember, because all of their cells are a combination of A and S, again, this is where the concept of the patient having red blood cells that behave like someone with sickle cell trait comes in. And so as long as there's pancellular expression, they have near normal total hemoglobins, and all of those, their cells produce this therapeutic normalized hemoglobin A T87Q. What's also important is looking at patient-reported outcomes, and this is using the Promise 57 NIH toolbox that actually is asking patients to rate their quality of life on a variety of scales, including pain intensity, fatigue, physical function, depression, anxiety, sleep disturbance, and social function. And whether this was an individual who felt that their quality of life was very much worse than the general population, or someone who thought that their lives were not so bad, no matter which category a sickle cell patient fit into, all of them showed improvement when evaluated at 6 months, 12 months, and now we're out to 36 months in this particular clinical trial. They all showed improvement in their quality of life. I'm going to switch and talk about gene editing, which is very similar to gene addition in that their stem cells are collected and then sent to a laboratory, except instead of the modification being lentiviral transduction, they have genome editing performed, and then those modified stem cells are returned to the patient's body. And this is what's been done in the CTX001 or exa-cel trial. For the first time, this was the first time that CRISPR-Cas9 technology was used to treat a human condition. And it targets a gene called BCL11A. Now, BCL11A does not produce any globin gene. This is an example of a gene that actually is responsible for modifying the expression of a globin gene. So normally BCL11A encodes a transcription factor, and that transcription factor is responsible for inactivating the expression of fetal hemoglobin, and that is why there is a natural period early in infancy where babies go from making fetal hemoglobin to making adult hemoglobin, and that's largely due to BCL11A. When they stop making baby hemoglobin, they start making adult hemoglobin, which incorporates beta globin. But in the case of sickle cell, that beta globin is only hemoglobin S. And so the main thing that we hope to do here is to really suppress the ability to actually make that conversion. And this is what it essentially looks like following screening. Patients have their CD34 cells collected after they've been mobilized with plerixafor. Those cells are sent to the laboratory, enriched for the very most primitive form of stem cells called CD34 positive stem cells. They're electroporated in order to introduce the guide RNA and the caspase in order to make the edit that should be therapeutic. Their cells are then cryopreserved. They undergo release testing for safety, and then they're returned to the site. The patient, just like the previous one, they undergo busulfan myeloablation, and then their cells are infused, and then they're watched for signs of engraftment of white cells and platelets, as well as early indications of the effects of the exa-cel gene therapy. And this is what what we've seen in this early study. So this is looking at the reduction of severe vaso-occlusive pain episodes in individuals who have undergone exa-cel gene editing gene therapy. Again, each one of the bars represents an individual patient, and on the left you'll see an area where there are multiple blue diamonds, each one of those representing a healthcare encounter for vaso-occlusive pain prior to gene therapy. That gene therapy was at time 0, and then there's monitoring afterward. Now the top portion on the right is the folks who had reached the period where endpoint could be evaluated. And in this trial, almost 97% of the people who had reached who made up the primary efficacy data set had no additional severe vaso-occlusive pain episodes. The individuals that are across the bottom have had more time, and increasingly they are also pain-free. But this data was the basis for application for FDA approval of this product. I want to touch just briefly on, I think Dr. Sharma did as well, on some of the current clinical trials. This includes one called lentiviral, the lentiviral vector that actually targets BCL11A, but in a way that's very different than the gene editing approach. This used a gene addition approach using something called short hairpin microRNA interference that again targets BCL11A to turn it off to allow fetal hemoglobin to turn back on. And this is data on the first 6 sickle cell patients that were treated at Boston Children's Hospital. All of them began making large amounts of fetal hemoglobin with near normal total hemoglobins and the resolution of pain. This has now led to the opening of a phase 2 multi-center trial that is ongoing, that is near complete enrollment. And so we're very excited about seeing this approach being done now in more patients, and hopefully we'll move to an opportunity for it to be evaluated for approval. EDIT 301 is another approach that's in clinical trials. It's very similar in that the stem cells are mobilized, the CD34 cells are collected, but instead of using CRISPR-Cas9, this uses a more specialized Cas-base called Cas-base 12A, which we hope will increase the specificity and reduce the risk of unintended editing. But it's otherwise quite similar to the other approaches in terms of the editing that takes place in the laboratory, reinfusion after busulfan conditioning. And these are the first 10 patients that have undergone this approach. Again, patients who have had frequent vaso-occlusive pain episodes prior to gene therapy. And in this one, this is the Reni-cel trial. All of the patients have been pain-free following the infusion. Now, the caveat is that these are fairly short follow-up, and so I think we have to stay tuned, but certainly a very good early signal, but we certainly need more time. What's also very exciting about this particular study is that we see the expression based from gene editing very early. And so this one, what we want to accomplish is the expression of fetal hemoglobin. And you can see that in the orange that in 2 or 3 months, we're seeing 30 to 40% of the hemoglobin in circulation in these individuals is now fetal hemoglobin, and that their total hemoglobins, which is the number across the top, are within the normal range for both men and women. And so certainly very exciting early results from the Ruby study using Reni-cel. Base editing is a new approach that's important for us to think about. So when I think about CRISPR or any of the other nuclease editing platforms require a double-stranded DNA break. And whenever you cut across both strands of the DNA, there is a possibility of errors, the indels that Dr. Sharma mentioned, when the repair is complete. Base editing does not require double-stranded breaks, and it converts a single base pair without double-stranded breaks, which theoretically should actually give us more confidence in terms of safety. And that's what's being undertaken in Beam 101, another clinical trial, where the mutation's in a different site. It's actually upstream of the gamma globin genes, but the hope is that the mutation that will be made with base editing will result in high expressions of fetal hemoglobin that will mimic the hereditary persistence of fetal hemoglobin, which conceivably could be protective for patients with either sickle cell or thalassemia. This clinical trial is now open. It has now reached full enrollment of the adult cohort, and we're very excited about the early results on that one. There are certain factors that affect the efficacy of gene therapy, and that includes the severity of organ injury, which is similar to stem cell transplants from a related donor or an unrelated donor. We have to make sure that we ablate the marrow. I already discussed why, in order to make space, in order to reduce the percentage of their stem cells that still can only make sickle hemoglobin. We want to be sure that the progenitor cell dose, the dose that they're given back, is followed closely, because there probably is a minimum amount of cells that one needs to be given back for it to be successful. In the case of gene addition, we really follow the percentage of the cells that have been corrected or modified. We do something slightly different for gene editing, but this is also really important. I've mentioned pan-cellular expression, such that when we look at the red cells that are being produced after gene therapy, we need to hopefully measure and look for approaches that will give us near pan-cellular expression. Of Question about age is still to be determined, but it's still an important one for us to think about. Toxicities from gene therapy are related to the conditioning by and large, including mouth sores, hair loss, liver problems, lung fibrosis, and potentially risk of second malignancies. With gene therapy, there's a risk of graft failure, delayed platelet engraftment compared to other kinds of transplant, clonal dominance or insertional oncogenesis, which are pre-leukemic or precancerous conditions, off-target gene editing, which in theory could also predispose one to cancer, and then infertility, that's primarily related to the busulfan. Dr. Sharma has already alluded to the 2 FDA-approved products, which were approved in December of 2023. Epicel, which is now commercially called Casgevy from Vertex, has been approved for patients over the age of 12 with sickle cell diagnosis with no restrictions, with the primary indication, however, being those who have severe pain. Bluebird Bio is a manufacturer for Lovocell, which now commercially is called Lyfgenia. It's been approved in the United States for 8 patients over the age of 12 with SS or S beta 0, again, primarily for recurrent pain, and these are the price tags, which begs the question about access and equity. Once these new therapies are available, will they be out of reach for some or for many? I'm going to pivot, though, to talk about, am I a good candidate for gene therapy? And these are some of the factors that I think are important to consider. It's important to consider your sickle cell subtype, your alpha thalassemia status, the frequency of hospital admissions, age, complications and comorbidities, and the procedural burden. All the gene therapy recipients to date have either had SS or S beta 0 thalassemia. There is no data on other genotypes from clinical trials. Because there is no data on other genotypes, it may be more difficult to obtain insurance approval for other genotypes without that data. The current research studies that I've already mentioned focus solely on SS and S beta 0 thalassemia. Having said that, there are discussions that are ongoing with more than one of the gene therapy companies about launching a completely separate clinical trial to consider evaluating the other genotypes. Alpha thalassemia is due to mutations or deletions in the alpha globin genes, which can be co-inherited with sickle cell because it actually is inherited on a different chromosome. Altered alpha globin production usually causes no symptoms, and so the vast majority of individuals with alpha thalassemia trait or with sickle cell and alpha thalassemia trait have no symptoms. Gene therapy outcomes may be impacted by imbalances between alpha and beta globin production. And so it's so important to know your status. And so my recommendation is ask your hematologist about genetic testing or DNA testing for your alpha gene status. Age does matter, at least in the context of our current knowledge in gene therapy. The participants in the clinical gene therapy trials were between the ages of 12 and 35 years of age. There are pediatric studies looking at patients that have enrolled patients less than the age of 12 that are currently ongoing. In the absence of safety and benefit data in younger or older patients, gene therapy programs may be reluctant to consider some candidates, and insurance carriers may deny coverage. We're hoping that this changes, in particular for older adults who have been well managed, in particular those who have been very compliant with hydroxyurea and have good organ function. Certainly some of us will try to get approval, but my opinion, my recommendation right now for them is to stay tuned with respect to age, and then hopefully we'll know something soon about people under the age of 12. The frequency of admissions is based on the criteria that was used in the clinical trials. So the clinical trials required at least 2 admissions or encounters for pain requiring opioids per year for the 2 years preceding gene therapy. And I think all of us recognize that this is not the only indicator for severe sickle cell, but I can see that this is the primary one that was used for an endpoint with the FDA. The other real critical question is will gene therapy work for chronic pain? The mechanism for chronic pain may be different than the pain that's associated with acute vaso-occlusion. There is those who have high acute rates of admissions have been excluded from some of the current curative therapy trials. We know that from the allogeneic or sibling donor transplant experience that for those who have chronic pain, it may take far longer after either transplantation or gene therapy to have pain resolve. And so it may take over 1 to 2 years after gene therapy if one has chronic pain going into gene therapy. Complications and comorbidities matter because if one has to have adequate kidney, liver, and cardiovascular function for any kind of therapy, of any kind of transplant, whether that's gene therapy or allogeneic stem cell transplant. A history of stroke or abnormal TCD in sickle cell is currently not included as a qualification for gene therapy, even though certainly it would qualify you for an allogeneic transplant. And prior malignancies, HIV infections, or acute viral hepatitis would be exclusionary. And so these are some of the complications or comorbidities that have an impact on the ability to move forward with gene therapy. My recommendation is to work with your hematologist to optimize all your disease-modifying treatments, including treatments for things like kidney and your cardiovascular disease, high blood pressure, all of those things. If you can optimize all of your treatments, it improves the likelihood of your being acceptable for gene therapy. The procedural burden, I think, is the one that is causing most questions among patients, and it's important to understand the patient journey. So even once you begin on this process, recognize it could take you 6 to 12 months from the time that you visit with someone for a consultation to the time that you actually complete gene therapy. The screening procedures require extra outpatient visits and usually take 2 to 3 months to complete. The stem cell collections take 3 to 4 days and many times requires more than one admission to complete a collection of adequate numbers of cells. The schedules that we're seeing right now for commercial gene therapy products has been variable, so that one can expect there could be delays up to 6 months before your gene therapy product is returned to your site. Admissions to receive your modified stem cells back typically are 4 to 6 weeks, but if there are any complications, that admission could be far longer. Also, that even once is actually discharged, you may need some additional period of recovery at home for 1 to 3 months before resuming normal activities. The FDA expects commercial recipients to be followed for up to 15 years. And so it's very important going into gene therapy to have the mindset that we expect gene therapy patients to still remain in care. And so even those that are receiving commercial gene therapy, that they must plan on visiting a site that is knowledgeable about gene therapy at least annually for some time. Coverage for fertility preservation may vary by state and by insurance carrier. And so my recommendation is to work with your family, community-based organizations, and gene therapy programs to identify support resources up front. I also want to call your attention to a new tool that was just released by the American Society of Hematology. This was created in collaboration with the Mayo Clinic's Shared Decision-Making National Resource Center. That is a tool that's to be used by a patient in collaboration with their clinician to facilitate the conversation about your interest in transplantation. It covers things like what's not going well with your current therapy that would prompt you to think about transplantation or gene therapy. What some of the issues are, we've touched on some of them today, but allows you to walk through those point by point with your doctor. And then what are reasonable decisions based on your personal preferences? So in summary, we've made progress with sickle cell that's extended the lifespan. We now have, with optimal use of disease-modifying therapies, many people have found their sickle cell to be far more manageable, but disease-modifying therapies are not curative. The results of the gene therapy clinical trials have been very promising, with the majority of sickle cell patients now being pain-free, and the first 2 gene therapy products are now commercially available. There are additional gene therapy approaches that are under study in clinical trials and are absolutely worth discussing. Infertility remains an important issue, primarily due to conditioning that's currently used for all forms of curative therapies. There are conversations and there are research studies that are under development to look at non-myeloablative, not so much non-myeloablative, but certainly targeted conditioning that just simply targets the germs, the stem cell. And so it certainly is possible that perhaps infertility on the basis of conditioning may change at some point, but that individualized approaches to curative therapies are needed. And with that, I would thank you for your attention.
Thank you, Dr. Thompson. Will you be around for questions in a little bit? We've got 3 other speakers.
I'm trying to hold a second, just try to see if I can escape and get out of this one.
Okay, well, okay, all right, so that was a lot. All
Yeah,
right,
it was.
so, thanks. Yes, so our next step is we're gonna hear from our, I'm gonna throw your name, Henry, Dr. Henry, and she's gonna talk to us about this major topic of access to these treatments. What does that look like? What does that mean? After she has her intro, then she'll start her slides.
We are excited to begin our next session titled Access to Treatments, featuring a remarkable speaker who brings a wealth of knowledge, experience, and expertise to the sickle cell community. I'm delighted to introduce Dr. Artangela Henry. Dr. Henry is a passionate advocate for sickle cell disease, a healthcare consultant strategist, and a nurse practitioner, with a focus on preventative care and disease management across the lifespan. She is dedicated to advancing research and treatment for sickle cell disease in the adult population. Dr. Henry has nearly 2 decades of experience in healthcare and currently practices in Memphis, Tennessee. In this session, Dr. Henry will provide valuable insights into the challenges and opportunities surrounding access to treatments, the impact of innovations like gene therapy, and what it takes to make these therapies accessible to those who need them most. Welcome again, and thank you for being part of this important event.
Thank you for that amazing introduction. I mean, that just made me feel like a superstar. But we do understand that the real superstars are the ones that are in this room, and they are our warriors and the caregivers, so give it up. So what I do understand is I am the person that stands between this presentation and a break. So I am going to make sure I get us to our break, all right? While we are preparing to break, I would encourage each of you to pick up your cups, take a sip of water, stretch if you need to before we make that break. I've been watching. I haven't seen anybody drink anything since I've been up here. Okay, very good, very good. All right, today's discussion is access to treatment and the financial impact of sickle cell disease. And so we will go through this. I'm gonna make sure the clicker works, the green one. The big green button. Thank you. All right, so these are my disclosures. I am a compensated speaker for Pfizer Incorporated, as well as Emmaus Life Sciences Incorporated. Some images that will be used today are from St. Jude Children's Hospital, and they are being used with permission. This presentation is for educational purposes only. We are learning about gene therapy and what that looks like for our community. So we are all learning this information together. As far as disease state objectives, today we will kind of discuss the estimated amount of costs for sickle cell treatment in regards to gene therapy. Then we're going to review some complications of sickle cell disease and what that looks like, simply because we can't talk about gene therapy without really understanding the basics of sickle cell disease. We're going to identify some hidden costs that we typically don't think about, and then we're going to review some plans of coverage of gene therapy. So now we're going to go into sickle cell basics, just a few basics. Dr. Sharma and Dr. Thompson did a phenomenal job of really highlighting gene therapy and what that looks like. You're all experts in this room with understanding sickle cell disease and what that looks like for you individually. I'm going to break it down just a little bit so we can see the big picture and what's leading us to gene therapy. So a hemoglobin molecule, what is that? What is hemoglobin? Hemoglobin actually is a protein, and it helps to carry oxygen throughout the rest of the body, right? We all need oxygen to be carried to our organs. So it's actually comprised of 2 beta globins, 2 alpha globins, and 4 hemes that are attached right in the middle. The heme is what actually carries the oxygen. It's rich in oxygen, and it helps oxygen flow throughout the body. So when you look at this picture here, I want you to think about this is a hemoglobin molecule. This is what is carrying oxygen throughout my body. So as we move forward, what we know about sickle cell disease is that it's actually red blood cells that are deoxygenated, or it does not have enough oxygen within the red blood cell itself. So if you look at this picture here to your left, that's the same hemoglobin molecule. And what we see is those areas that are circled, those are areas where the heme is actually deoxygenated. That leads us to any red blood cell that is deoxygenated leads us to having those stretched fibers, okay? Those stretched fibers actually have a name. That process is called polymerization. That's when those fibers are stretched. That red blood cell is no longer round like a normal red blood cell, but they are sickle shaped. And so you can see that in this graphic of the blood smear that you see over here. So big round red blood cells, and then those sickle cells, you see there where the arrow is pointing. So this is the whole schematic view, so to speak, of sickle cell mutation that leads to hemoglobin S polymerization. All of the scientific jargon that we use, this is what this means. Their red blood cell is deoxygenated. So when we have these deoxygenated red blood cells, it leads to sickle cell vaso-occlusive crises. Now, it's not just the red blood cells and the sickle cells that are causing occlusion or the vessel itself from being clogged up. It's actually the red blood cells, white blood cells, the platelets, every single blood product that is in our vessels, in our bodies, is playing a role in vaso-occlusion, okay? So what does that mean? When those rigid red blood cells that are sickle cells compact with white blood cells and platelets and round red blood cells, it can cause a traffic jam, so to speak, and that's how I typically explain it to children in our vessels. When that happens, that's when you start feeling the pain, or those who are living with the disease, that's when they feel the pain, because there's not enough blood flow or oxygen getting to the area. Because remember, we're talking about hemoglobin that's deoxygenated, and we need the oxygen to go to every organ. So this is just a pictorial view of what that could potentially look like, or what that looks like. Because of these vaso-occlusive crises, or the traffic jam that happens in the body, it leads us to multi-organ damage. This happens simply because there is not enough oxygenated blood going through the body. Now, sickle cell crisis can happen anywhere that blood flows, literally from the brain down to your toes. So if you're not getting enough oxygen to those areas, it can cause damage to those organs and the vessels that's leading to those areas. So now we have a situation where it's not just sickle cell disease, but it's everything in our bodies. Everything in your body is affected. Every single organ, every single vessel. So that makes sickle cell disease very complex. You have to make sure that you are investigating what's going on if someone shows up with a sickle cell crisis, okay? The pain is what we call a prodrome. It lets us know that something is happening in the body. It may not just be pain. It can be acute chest syndrome. It can be strokes that are happening. It could be a vascular necrosis. So we have to investigate, because every single organ is being affected. Not only is every single organ being affected, but this starts at birth, and it does not end. Sickle cell disease, the complications of sickle cell disease happen 24/7. If those living with this disease are not in pain, that does not mean the damage is not being done. You can not be in pain and feel fine, but damage is still being done because you still have red blood cells that are sickled. They are rigid, they are hard, and they are literally scratching the inside of your vessels, and they are blocking good oxygenated blood from flowing to the places that you need. Damage is done every second, okay? With that being said, it starts in infancy, and then it transpires over into adulthood. It's like a building block. It's almost like building a house. You have the foundation of sickle cell disease, and each brick that is laid is another complication, and it doesn't stop. The same complications that you have in infancy can lead up to childhood, adolescence, and even later adulthood. And so a lot of these instances are irreversible and some are, but the damage is there and it's being done. So what does that say about sickle cell disease? Number one, we know that it is a very complex disease process, and it's definitely more than just pain. And it's definitely more than just the quote unquote Black disease. But because of the complexity of the disease, it leads to high financial cost, even without gene therapy. And so when we bring the nuances of gene therapy into the conversation, we have to also ask, what does that look like from a financial perspective? So now we're going to go a little bit into the financial impact of treatment, and that treatment being specifically gene therapy. So when we think about the financial impact of sickle cell disease itself, that's enough. But gene therapy, we know by research and even by the clinical trials that the costs range between $2.2 to $3.1 million annually. And that's just for one case. That's one treatment, okay? One treatment. And so you can see here the 2 FDA-approved gene therapy treatments that are here on the market now and what those estimated costs are per case. We also know that with this treatment therapy, again, Dr. Sharma and Dr. Thompson gave us a wonderful picture of what that looks like and the stepwise approach of what we are to expect with gene therapy in regards to actually receiving the treatment. But what about the recovery time? What about after the treatment is completed? So some of those challenges leading to hidden costs are some of the things that I want to think about now and want us to kind of lean into. Number one, transportation. And keep in mind, this is probably after you've received the therapy, because during therapy, you're going to be in the hospital. After therapy, what does life look like? Transportation. You still have to go to follow-up appointments. Transportation back and forth. Designated care home. Are you in an area where you can easily get to your healthcare provider? Are there enough providers in your area who understand sickle cell disease, and not only sickle cell disease, understand the new therapy for gene therapy and what that looks like? Time off work. And this is not just the adult patient. This is also not just for the adult patient because they have to work, but this is also for the caregiver. The caregivers have to take off to be able to take care of their children. Remember, this therapy is approved for those 12 years of age and older. The caregivers have time off work. If you have time off work, that's no money coming in. How are you paying your bills? How are you keeping the lights on? So we have to think about those and make sure that there are plans in place. Hospital stays. The hospital stay can be long. This is a therapy that will encompass a lot of treatment, a lot of care, a lot of experts on the case. So thinking about the hospital stay and what that looks like. I mentioned caregiver lost wages. Also understanding the access to treatment. Is this a treatment that's right for me and my family? Can I have someone in my area explain to me what that looks like? Really break down gene therapy in a way that's easily digestible and I can understand it and help me walk through that process. Insurance coverage. That's another story for another day. Lack of providers with specialized training is another. We see this much too often where there are not enough providers who understand sickle cell disease. And so if they are not understanding the disease, do they truly understand the reason why I may or may not be a good candidate for gene therapy? And is this someone I need to be able to discuss with my health, Lodging. A lot of centers who will be approved for gene therapy may not be in areas that you live in. Where will your family stay? Hotel, Airbnb, that comes with a cost. Food and nutrition, not just for the individual that's going through gene therapy, but also for the family, for the support person. Making sure that you're hydrated, eating good, healthy foods to help your body stay healthy so you can continue to fight this disease. What does that look like? That's a hidden cost we hadn't thought about. Who's paying for food and nutrition if you're off work to help your loved one or to help yourself. And then last but certainly not least, what we tend to always leave out of these conversations is psychological support. That is truly a financial cost. It's an emotional cost. It's a cost that we have to address. Am I someone that is able to go through gene therapy, knowing that I have to go through chemotherapy? And do I have the support system? Sickle cell disease is a chronic disease. All chronic diseases, not just sickle cell disease, comes with anxiety and depression. Do you have the support system to be able to help you through that? Do you have the resources to have some good psychological support? That comes with a cost. So these are just some of the hidden costs that leads to genetic therapy. Make sense? Have we thought about these costs? Most times, no. What we've thought about is the treatment and getting the treatment paid for and what that looks like, but not everything that comes around that. And so when we think about sickle cell disease, it has to be holistic care. You have to make sure we're treating the entire patient, the whole body, mind, body, and soul. And that's with any treatment. Have to be very unbiased about treatment because sickle cell disease is very individualized and our treatments will not work for everyone. But it's important that we make sure we address a lot of these hidden costs that are there. All right. So treatment coverage. So this is a lot of what we probably wanted to come here today about. I would say that the answer to this is in the heavens, so to speak. So what we know for certain is that the Center for Medicare and Medicaid Services, which is also CMS, their aim is to actually improve access, quality, and experience of healthcare for individuals living with sickle cell disease. And so that's a huge aim. That's a huge aim to have, but it's also a very good aim to have because what that lets you know is that there's someone that is on your side that wants the absolute best for you, okay? With that being said, about 50 to 60% of individuals with sickle cell disease are on Medicaid. And that varies from state to state. Every state is not the same. California would not be like Tennessee. Tennessee will not be like New York. And so we have to have an understanding or at least have someone who can advocate that understanding of what each state Medicaid program looks like, okay? So we have individuals that are enrolled in Medicaid. There's also CHIPS. And so if you have your phone and you're able to do this QR code here, just scan this because what this gives you is an infographic of Medicaid and CHIPS. CHIPS is Children's Health Insurance Program. And this particular graphic will actually show you the beneficiaries of Medicaid and CHIPS, all from CMS. And it shows you by state how those services are going out with percentages. So there's some data included with this, some good metrics with this. So just scan this code and just keep it in your back pocket just to look, okay? So the big question, who pays for sickle cell treatment? The easy answer for this is, we're not sure. We're waiting to see who will pay for gene therapy, okay? And this is why. The CMS is developing the cell and gene therapy access model, and this model is being developed to increase access to innovative sickle cell and gene therapies for people with Medicaid. CMS is working very closely to be able to make this happen. They announced what's called the CGT access model to expand not only to those individuals who may need genetic therapy or gene therapy in other instances, but also sickle cell disease, specifically sickle cell disease. And so the model will include outcomes-based agreements between manufacturers of the actual treatment itself and state Medicaid programs. So again, that circles us back to my original statement. Every state Medicaid program is different. If your specific state is not in agreement or does not have a designated center that specializes in gene therapy or providers who specialize in gene therapy, there's an opportunity that particular state may not be a part of this program. There is some work being done where there may be some instances where individuals who do not have a center that will perform these types of therapies can go to another state. But again, you will have to speak directly with your state. So now we need some advocates, we need some lobbyists, we need some people on the legislative portion of this journey to help us through this. This conference, we talk a lot about the medical side of things and even talk about the mental side of things, but now we need Congress, now we need legislators, now we need to fight more of a political stance to have this type of therapy available in individual states, all right? So this model will begin January 2025. That's coming soon. That's great hope. But the question is, what states will adopt this particular program? So treatment decision-making. Who makes the decision for treatment? So it's multifaceted, okay? First, we have shared decision-making, and that's between the provider, the patient, provider meaning your healthcare provider, your doctor, your nurse practitioner, your healthcare team, the patient, the one who's living with sickle cell disease, and then the caregiver, if it's an adolescent or a child, or minor child. And the reason that shared decision-making is there is because it takes all hands on deck, number one. Number two, your provider should know your health history and should know if you are a good candidate for gene therapy. The second piece to this is, are there centers and providers in my area that specialize in this treatment? Where are they? If there's no center or provider in your area, what do you do? And then the eligibility criteria for gene therapy, what that looks like. So I have another, I'm gonna move ahead just so you can go ahead. I want you to scan this QR code simply because it gives you a PDF of the eligibility for gene therapy based on CMS. I want you to be equipped with this information so you have it. So after you've scanned it, I'm gonna go back. Just because I've already outlined what the eligibility is, but this way you will have something, a reference that you can actually use. Number one, you have to have a documented medical diagnosis of sickle cell disease, be enrolled in Medicaid or CHIP, if applicable, in a state participating in the model at the time of therapy, have Medicaid as your primary payer, and receive gene therapy from participating manufacturer. So we have two. You also have to meet the standardized prior authorization criteria that is established by this treatment-based agreement that is within the actual gene therapy program itself. So this is the eligibility criteria. This is outside of talking to your provider to see if you are a good candidate or not for gene therapy. All right, so you scan that. So I told you I want to make sure that I'm not holding you up for your break. In summation, what does this look like as a whole? Number one, what we know is that sickle cell disease is a complex disease that affects the entire body. The complications of sickle cell disease overall increases healthcare costs, but even with newer therapies, there's an increase in that particular cost. Now, the good thing is if gene therapy is for you, is the treatment of choice for you, and it works well for you, it can bring some good quality of life. It can actually decrease healthcare costs over time. But right now, in this moment, we know that these complications are situations where there is an increased cost. There are a number of challenges that are leading to hidden costs that we have not taken the time to really peel back. We need to look at those hidden costs and develop a plan to be able to face those head on if the decision for gene therapy is made. Again, gene therapy has been FDA approved as a treatment option for those who are living with sickle cell disease who qualify. The good thing is CMS is working very hard to develop a cell and gene therapy access model. This model will take place January 2025, so there's so much more to come with this. And there is hope. There is always hope on the horizon for sickle cell disease. And we've seen this over the last 7 years. We have increasingly been getting more hope for treatment, more hope for centers, more hope for those who are advocating for the disease itself. And so what we know is we are here. There's no turning back and going back. We have to move forward. But in moving forward, we have to develop a good plan and have a good support system that helps us along the way. These are some references. I want to thank you for your time and your engagement during this presentation. And I know that we will have questions at the end. I'm not the moderator, but I do understand that it's time for a break. So thank you.